Certainly, pericardial effusion is the most frequent disorder of the pericardium that you will encounter. And of course, pericardial constriction is very important as well because it has a lot of consequences for the patient. But there are also other diagnoses that you can make which relate to the pericardium. Pericardial cysts are fairly uncommon benign tumors which represent approximately 6% of mediastinal masses and 33% of mediastinal cysts. They are believed to form because there is failure of fusion of mesenchymal lacunae that form the pericardial sac. They contain clear serous fluid and are usually asymptomatic unless they are very large and cause compression of neighboring structures. They can be unilocular or multilocular, and the most common region where you will find them is that of the right cardiophrenic angle. Here's such an example of a typical location of a pericardial cyst. You will find the cyst right here beside the right atrium. To better visualize and investigate such cysts, it is advisable to move the transducer more towards the right. Here you will see a very large cyst with a partial septation. If you use color Doppler, you will note that there is no flow within the cyst. Color Doppler, and also pulse wave Doppler by the way, is very helpful in differentiating a cyst from other pathologies which might be connected to the heart, such as diverticula or other vascular abnormalities. Pericardial cysts are often incidental findings, often detected first on a chest X-ray. Here is such an example where you see a very large cyst on the left side of the heart. Even though we can see such cysts with the help of echo and we can even suspect the diagnosis, in reality it's better to also use other imaging modalities. Here is an MRI image which shows you such a large cyst. As a matter of fact, this is the same cyst we saw previously in the chest X-ray, located here in proximity to the left ventricle. What is the differential diagnosis to pericardial cysts? Well, localized pericardial effusions, hepatic, renal, and mediastinal cysts, echinococcal cysts, diaphragmatic hernias, atrial diverticula, and aneurysmatic vessels, for example, if we have an aneurysmatic bypass graft. Here is an example of an abdominal hernia and how we can distinguish it from a pericardial cyst. All you have to do is let the patient drink some fluid which contains gas, for example, Coke or soda. What we will see is bubbles within the structure, which represents the gas within the fluid that fills the abdominal hernia. From a fairly benign disease, we will now turn to malignancy. Malignant pericardial disease. Malignant involvement of the pericardium can occur as a primary malignancy, in the form of metastasis, and in the form of pericardial carcinosis. Metastasis in pericardial carcinosis is the result of a secondary involvement of the pericardium, with pericardial carcinosis being a more diffuse process. This CT shows you an example of a very large tumor of the pericardium, which turned out to be a metastasis. But how frequently is the heart involved in the setting of malignancies? Well, at autopsy studies, we find cardiac involvement somewhere in the range of 12 to 15%. The pericardium is involved in 76% of these patients. And we have approximately 34% of these patients who have a pericardial effusion. So what do we learn? Well, pericardial involvement is rather frequent. In general, somewhere between 8 to 15%. It is often associated with pericardial effusion, but not always. And what is also important, if a patient has a primary tumor and he also has pericardial effusion, it does not necessarily mean that the patient has pericardial involvement in the sense of carcinosis or metastasis. There are also other reasons for a pericardial effusion if someone has cancer. But in general, if you find a pericardial effusion in someone who has cancer, then there is a fairly high likelihood that he has pericardial involvement in some form. And what does it mean if someone has pericardial effusion in the setting of cancer? Well, it means a poor prognosis, especially if pericardial effusion is symptomatic. Then the patients have a median survival somewhere in the range of only 4 months. This is such a patient who had lung cancer and who developed a very large pericardial effusion with a swinging heart. This patient was symptomatic and pericardial drainage had to be performed. Nevertheless, the patient died only 6 weeks later. But can we directly visualize carcinosis of the pericardium? Well, unfortunately not. It is always an indirect diagnosis. But in which forms of cancer is the likelihood of pericardial involvement particularly high? In lung cancer, breast cancer, cancer of the esophagus, and in lymphoma. But you can also have a pericardial involvement in the setting of a primary cardiac tumor. And if you see a mass in the heart together with a pericardial effusion, as in this example, then the likelihood is very high that this tumor is a malignant tumor. This is another example, a very large tumor in the right ventricle, pericardial effusion. This was a rhabdomyosarcoma, a malignant tumor. The last disease of the pericardium that we will be discussing is a congenital abnormality. A very rare congenital abnormality, but probably one which is underdiagnosed. We will be talking about congenital absence of the pericardium. It is found in approximately 1 of 10,000 autopsies, often associated with other defects in 30%. It can involve only the left side of the pericardium, the right side of the pericardium, or there can be total or complete absence of the pericardium. Patients are usually asymptomatic, but they can have chest pain. They have a higher risk for traumatic aortic dissection, but the main risk is that they develop cardiac herniation or strangulation. How do we diagnose it with echo? Well, the following features can be present: displacement of the heart, excessive cardiac motion, abnormal septal motion, and an enlargement of the left atrial appendage. Some of these features can be seen in this example. We have an abnormal configuration of the heart. Look at the right ventricle here. We have an abnormal septal motion and excessive abnormal motion of the entire heart. We also had a very abnormal position of the heart. The transducer had to be placed very far on the left side of the chest to get a parasternal long axis view that you can see here. Again, look at the abnormal configuration of the heart. It is not possible to directly visualize the absence of the pericardium itself. To suspect the diagnosis, you have to look at the configuration of the heart, the motion, and its position. To confirm the diagnosis, I would also recommend to use other imaging modalities. I remember at the beginning of my career, when I really didn't have very much experience, I was sent to perform an echo in the emergency department because there was a suspicion of pericardial effusion. And I said, well, I don't really have much experience. And the coworker said, well, all you have to do is put the transducer on the chest. It's easy to see a pericardial effusion. Well, sometimes it is, but as this chapter shows, not always. Some pathologies can be very complex to really diagnose and to interpret. Keep this in mind.